Hello, everyone. It is my pleasure to welcome you to the webinar of tonight, the webinar of ERN-EYE, with as a topic, genetic testing strategies for rare eye diseases. So the goal of the today's webinar is to elaborate on testing strategies, genetic testing strategies for rare eye diseases. There are three speakers. Apart from myself, also Dr. Haer-Wigman and Professor Frans Cremers from Radboud University in Nijmegen will talk about variant interpretation and variant collection and interpretation. I will talk about the genetic testing strategies. So first of all, let me introduce myself. I'm working as a clinical geneticist and a clinical molecular geneticist at the Ghent University Hospital and Ghent University in Belgium. And I am co-chairing the Transversal Working Group 6 on genetic diagnostics within ERN-EYE. And I have a special interest for genetic testing of rare eye diseases. And today I will talk about inherited retinal diseases as an example. First of all, the rare eye diseases are a very heterogeneous group of conditions, as you know. The question is, if you have a patient with a rare eye disease, which genes you want to test and also how you want to test them, and these two are related. First of all, I show a patient with aniridia, which is part of the microphthalmia, anophthalmia, and coloboma spectrum. And there we know that the PAX6 gene is an important gene to test. Here in the middle, we see a patient with oculocutaneous albinism. And for this condition, if this is non-syndromic, we know that we can test 7 disease genes. And this is different from the condition, the inherited retinal diseases, which is very heterogeneous. And I show here the example of RP, where we know that we have to test over 90 disease genes. Inherited retinal diseases will also be introduced by Frans Cremers. We know that this is a very heterogeneous group of diseases affecting 2 million patients worldwide with a high prevalence, as you can see. And depending on the genes that are mutated, we have a rod-dominated or a cone-dominated phenotype. We know that apart from the clinical heterogeneity, there's also a large genetic heterogeneity. If we apply standard of care genetic testing or genomic testing of the known disease genes called the retina genes, then we can offer a genetic diagnosis in 60% of cases. And we also see that the genetic architecture of IRD is today predominated by coding variants with only a small fraction of non-coding variants so far. Regarding testing, we know for IRD that important advances have been made in the therapeutics of IRD. And depending on the disease stage, there are different options for gene therapy. It has been shown that timing matters, that an early diagnosis is crucial because then gene therapy is in some cases possible. So today I would like to elaborate on technologies for genetic and mainly genomic testing for rare eye diseases. And of course, I have to talk about sequencing. I show here a graph about the evolution of sequencing the last decades. I will not talk about the first generation of sequencing, which is called Sanger sequencing, which is basically serial sequencing. It is today we talk about second generation sequencing that evolved the past decades. It's also called next generation sequencing or NGS, and this has almost completely replaced Sanger sequencing. And the major difference between NGS technologies and Sanger sequencing is the multiplexing. It is not serial sequencing anymore, but parallel sequencing. Instead of one reaction per tube in Sanger sequencing, copies of templates can be sequenced with parallel sequencing, massively parallel sequencing, or multiplexed to clusters by in vitro amplification, mostly on a solid carrier, and this is called a flow cell. NGS consists on the one hand of cycles of biochemistry and imaging, and this process is called sequencing by synthesis, and this is today the technology that is most frequently being used in a clinical context. The short sequences of clusters are called reads, and you see reads represented here. These reads are aligned against a reference sequence, for example, a reference exome or a reference genome. After this, it can be assessed whether the mapped data differ from a reference sequence at certain positions where it was aligned, and this process is called variant calling. And then it can also be assessed whether possible genetic changes in the sequence fragments can be found. On the figure, we see different genetic changes. We see changes in a homozygous state where you see that all the reads are different from the reference sequence. And then here at the right, you see that about 50% of the reads differ from the reference sequence. Here we can appreciate a heterozygous variant. You also see coverage at a certain position. This is the number of reads that is aligned to a specific base. And this approach allows to detect sequence variants that include single nucleotide variants or SNVs, as well as copy number variants or CNVs. And these are important. The latter category is important. They are known to represent about 10% of genetic defects in IRD. And this technology has allowed implementation of NGS in healthcare for advanced genetic or genomic testing in IRD and also rare eye diseases. And today, with only one operator, for less than $1,000 or €1,000, you can do whole genome sequencing of one individual human genome. So far, multiple NGS-based studies have been conducted in IRD cohorts and also in other rare eye disease cohorts. And here you see the variety from targeted panel analysis, targeted exome sequencing to whole genome sequencing. This is not a limitative list. And these studies show an overall detection rate from 30 to 85%. And this is depending on the technology used, the patient cohorts included, and also the level of pre-screening. So now I would like to go over targeted next-generation sequencing. When do we use this? When applying next-generation sequencing with small gene panels. So targeted NGS is the approach where you sequence or either one gene or small gene panels. This is determined, the sequences are determined in parallel, and you do a physical selection, a so-called enrichment of genes that takes place first. Then these genes are looked at for variations that could explain the disease. What is typical here is that the role of variants in these genes in relation to the disease is well known. When do we use targeted NGS? I give here 3 examples in the IRD field. The first example is Stargardt disease and ABCA4. Here we have a relatively clear clinical question with a strong suspicion about which gene or genes are affected, and in this case, this is the ABCA4 gene. For ABCA4, we know that SNVs as well as copy number variants are possible, as well as non-coding regions can be mutated, so their sequencing of the whole locus is important. The second example is retinoschisis caused by variants in the RS1 gene. This is a relatively typical phenotype, and here we know that it's important to test the RS1 gene. This is an example where we know that it's important to look at non-coding variants and also at copy number variants. 2 loci are involved in North Carolina macular dystrophy, PRDM13, and IRIX1 regions. So here are examples of relatively clear phenotypes where we know that we have to look at a specific disease gene or locus. When a patient has an IRD for which it's not immediately clear which genes could play a role, whole exome sequencing-based panel testing can be chosen as a diagnostic tool. And today, this is in many medical or clinical labs, this is the standard of care as a first workup in patients with IRD. And an example of this is sporadic RP, for which mutations in over 90 genes account today. With West-based testing, how does it work? The entire coding portion of the human genome is enriched and sequenced. So basically, all protein coding information of all genes is enriched. In addition, bioinformatics gene panels, such as the RedNet panel, can be extracted from whole exome sequencing data. And in this case, gene selection is not done in vitro, it's not physically enriched, but is in silico extracted. where whole exome sequencing was a few years ago at the interface between research and diagnostics. It's nowadays widely implemented in clinical genetic testing, and it's specifically interesting to use for genetic heterogeneous diseases such as rare eye diseases. On the one hand, it can reveal mutations in known IRD genes. This is one of the advantages, using virtual gene panels in a routine setting. And then on the other hand, if a patient gives consent, it also allows the identification of pathogenic variants in candidate disease genes in a research setting. Regarding filtering, in one individual, about 20,000 variants are found in an exome of an individual that can be reduced to 200 private variants after standard filtering, and then this needs to be reduced to 1 or 2 variants that play a role in the disease pathogenesis. This is an example of West-based panel testing of the RedNet panel in a Belgian IRD cohort, and you see that the diagnosis, the molecular diagnosis, can be offered in about 50% of cases. We also see a high percentage of monoallelic cases and 25% of patients without a diagnosis. Whole exome sequencing has some limitations. One of the limitations is the challenge of detection of structural variants. Also, some regions are lowly covered, show gaps in the exome. And I will give an example. Here you see an example of CNV detection on exome data. We use exome depth in a routine context. This is an algorithm for CNV detection in exome data, and this is purely based on read depth. After mapping, the reads are counted, followed by a normalization and transformation step, and then the CNVs can be called as shown here at a simplified figure. You see the example here of a homozygous deletion of the CEP78 region. Here we have a normal copy number in the middle, and here at the bottom we have a heterozygous deletion where you see half of the reads mapped back to the reference sequence. Here we see a gap in the West data. Typically we know that we have a gap in the ORF15 region of the RPGR gene, and there it is well known that other approaches are needed to fill this gap in exome data, but also in genome data. For this, we address this using targeted deep sequencing, and then in the future, this will also be addressed by long-read sequencing. Some labs already use long-read sequencing. This is important to cover this gap because this is a target for gene therapy. Then whole genome sequencing is more and more being implemented also in a clinical context. This is sequencing of the entire genome without physically enriching a specific region. Here, the base order of all genes, as well as the non-coding parts of the genome, is determined, and this is one of the advantages. High coverage whole genome sequencing is only used to a limited extent today in a clinical context, and mutations outside coding regions of genes requires special attention for functional characterization and interpretation. It can be expected that in the near future, it will be more efficient and also cheaper to sequence a patient's entire genome and then filter for genes relevant to the patient's phenotype at that moment. It will become the standard of care approach in the near future. And the technique is developing in the direction of a generic genome test in which the selection analysis of genes is done in silico. And you see that a high coverage is needed here too. Here, as an example, I show whole genome sequencing in a relatively small pre-screened IRD cohort of 50 cases. And I show here the 4-step whole genome sequencing analysis. First, we look at coding sequence variants in IRD genes in the RedNet panel. This is the standard of care approach, and here we try to find missed variants using exome sequencing. The second approach is the identification of non-coding sequence variants in IRD genes, mainly in patients that are monoallelic for coding sequence variant. Then we look for structural variants in IRD genes, and the fourth analysis is we look there at variants in candidate genes. And then for the new variants in new genes, there it's often needed to move on with functional assays, which is not always possible in a routine setting. Functional assays such as minigene assays to assess splicing, or qPCR, for instance, to assess expression. Here we see then the outcome in the small cohort. We see that Coding SNVs in RedNet genes represent 8% in this small cohort. Also, structural variants, mainly copy number variants, represent 6%. We have then non-coding SNVs, mainly with an effect of splicing, that represent 18%. And then we also have sequence variants in non-RedNet genes in 18%. And we see that in this pre-screened cohort that 50% of cases remain unsolved. What is the expectation? Where do we go from here? One of the important current and future challenges is the identification of cryptic and complex SVs. Apart from the classical deletions and duplications, there are also inversions that are copy neutral, insertions, also translocations that are harder to find using the standard of care, karyotyping, molecular karyotyping, next generation sequencing based on short read sequencing. We have whole genome sequencing, and then we also have third generation sequencing that is emerging. And there we have single cell technologies, single molecule technologies based on long read sequencing or optical genome mapping. Here we see an example of third generation sequencing or long read sequencing based on the optical nanopore technology system, where you generate an ionogram, and this allows to infer the sequence of a molecule. And then we have a new technology, an emerging technology, optical genome mapping, that allows to identify cryptic and complex SVs. And this technology reveals 7 times more structural variants compared to short read sequencing only. It relies on fluorescently labeling specific DNA sequences, resulting in unique patterns for each section of the genome. And then after DNA linearization and imaging, optical maps can be generated that allow for the detection of large structural variants that are not captured by sequencing, as illustrated for rare diseases and also for many hematological diseases. So you see here a complex karyotype that is harder to detect using the routine technologies, the standard technologies. And here we have a published example where the combination of optical genome mapping combined with long read sequencing allows the detection of an inverted duplication in a family with chorioideremia, and this led to the solving of this family that remained unsolved after many years. Important aspect with the genomic technologies is the assessment of the pathogenesis of variants. This is takes an important part of our time apart from the sequencing. This will be the topic of the second speaker, Dr. Haer-Wigman, and will also be addressed by Professor Frans Cremers in the third talk. Here I would like to refer to an initiative from ERN-EYE, REDVAR, that is an initiative that assesses the pathogenicity of variants playing a role in rare eye diseases. And since last year, we have had 4 meetings, and we addressed variants in RPE65, which is a target for gene therapy. This was the pilot of last year, and we will expand the variant assessment to other genes that play a role in rare eye diseases. So this has taken place 4 times last year, and we will also have meetings this year. So you are kindly invited to send in cases and also to participate in these meetings. So there is clearly a clinical utility of genomic testing in rare eye diseases, in the first place for diagnostic purposes, but also to prevent prognosis. Also for reproductive options. In some countries, this can be used for pre-implantation genetic testing, for family planning, also for therapy, as already addressed. This is important to have an early genomic testing and an early diagnosis in patients with IRD, but also with other rare eye diseases. So genomic testing in rare eye diseases, today we make use of 3 levels of mainly NGS-based testing. Whole exome sequencing is becoming standard of care. Whole genome sequencing is evolving, mainly based on short read sequencing, which is implemented as a standard of care in many routine genetic testing labs. We also see that long read sequencing and optical genome mapping are upcoming. These are emerging technologies, but not that much yet in a routine context. The choice of the test is depending on the clinical diagnosis, and we also have to know the genetic architecture that orients the choice of the test. Also, the regional and the national context is important for the access to genomic testing. And then as a physician and also as a laboratory expert, you have to know the clinical validity and the limitations of the test. With this, I would like to end, and I would like to give the floor to the next speaker. The next speaker is Dr. Lonneke Haer-Wigman. Lonneke is working as a recognized clinical laboratory expert at Radboud University Medical Center in Nijmegen in the Netherlands. And she has expertise in the genetic testing of rare eye diseases, specifically in inherited retinal diseases, and also has expertise in variant interpretation. And this will be the topic of Lonneke's talk. So Lonneke, the floor is yours.
Thank you, Elfride. So indeed, I will tell something about the interpretation of sequence variants in rare eye diseases. So first of all, an outline. I will start by explaining why we need to interpret variants. Then I will explain why we need general rules for variant interpretation. Then I will show guidelines for variant interpretation. How can we interpret these variants? And at the end, I will give some examples in which we interpret sequence variants in rare eye diseases. So first of all, why do we need to interpret variants? Elfride already showed some data, but with exome sequencing, you get roughly 150,000 nucleotide variants. And within a panel for genes associated with inherited rare eye diseases, still 5,000 to 6,000 nucleotide variants are detected. In most cases, only 1 or 2 of these variants are relevant for the clinical phenotype of a patient. So most of them are not of any clinical relevance. And with variant interpretation, you can determine whether or not a variant is or could be clinically relevant for the patient. So why is it necessary? This is shown in this article, where a woman sued a hospital because she said that the doctors unnecessarily removed her breast and uterus. A genetic test was performed on her DNA, and then the doctor said that she had an MLH1 and a BRCA1 gene mutation, as well as Lynch syndrome. And therefore, she had a very high chance of developing breast cancer and a very high chance of developing uterine cancer. She got her breast and uterus removed, and then she was unhappy about the reconstruction of her breast, and she went for a second opinion. And this new doctor said that she had no MLH1 mutation, had no BRCA1 gene mutation, and also had not Lynch syndrome. And this shows that when you do not interpret variants, something really harmful can happen to a patient. But then why do we need general rules for variant interpretation? So you would expect that if a patient would give DNA to 4 different laboratories, and they will give a report that all 4 laboratories will give the same result and the same conclusion for this patient. But there are different quality assessments, for instance, the GenQA pathogenicity of sequence variants assessment that is performed every year. When labs get different variants, they just get the variant and then they're asked to classify this variant. And if you look at variant A, you can see that most labs classify this variant as pathogenic and some as likely pathogenic. But for variant B, there were labs who classified the variant as pathogenic and some as likely benign. So these are the opposites of the spectrum, and this can, of course, be very harmful for the patient. And also, again, an example that's been in the news about a woman who says that her 2-year-old son died because of a false DNA test. This son had severe epilepsy, and the doctors thought that the son would have Dravet syndrome. So they asked for a genetic test for the SCN1A gene, which is associated with Dravet syndrome, and a variant was found in this gene. The variant was classified at that time as a variant of unknown significance. So we don't know whether it's benign or pathogenic. However, at the moment of the classification, this variant was already reported in literature to occur de novo in a patient with Dravet syndrome. So it seems that already at that moment that this variant is not of uncertain significance, but should be classified as likely pathogenic. And this woman strongly believes that if the classification would have been different, then her son would still be alive. Of course, that's the question, whether that would make any difference. But this shows how important it is that variants are classified with general rules so that everybody can give the same classification if a variant is detected. So now I want to show you some guidelines about variant interpretation. So many guidelines have been published, but because of time, I will only go into the most commonly used guidelines, and these are the ACMG AMP interpretation sequence guidelines that have been published in 2015. That's already quite a long time ago, and therefore it's expected that at the end of this year or the beginning of next year, an updated version of the ACMG AMP guidelines will be published. But as these are not yet published, I will go into the guidelines that have been published in this article. So in the article, they show 16 criteria for the evidence of pathogenicity, and the first 5 are here shown on the screen. So for instance, one criteria is when the variant is a null variant. And another criteria is, for instance, where the functional studies have been performed and they show a damaging effect on the gene or the gene product. And in this paper, they say that not every criterion has the same weight. So they propose that a null variant has a very strong evidence for pathogenicity. So if you here look at the criterion, it has a name, PVS1. So the P stands for pathogenic, the V and the S stands for very strong. So they believe it's a very strong evidence for pathogenicity. And this is the first criteria in this weight for very strong. So PVS1 stands for a null variant. I just said also about the functional studies, that's called PS3. So in this paper, they propose that when functional studies show a damaging effect, that's a strong evidence of pathogenicity. So we have the P again for pathogenicity, the S for strong, and this criteria number 3 in all the criteria who have a strong evidence. So PS3 stands for functional studies that show a damaging effect on the gene or gene product. So these are the first five criteria, and here are the other 11 criteria. So next to very strong and strong, you also have criteria with a moderate evidence and with a supporting evidence. For instance, PM3, pathogenic, moderate, criterion number 3, PM3 can only be used for recessive disorders and can be used when a pathogenic variant is detected in trans in a proband that has your variant, which has the variant of interest. Also, you have supporting. Of course, then there was a problem with the naming because we have pathogenic, but the S is already used for strong. So then they use the P, pathogenic, supporting, PP. And then, for instance, number 2 is a missense variant in a gene that has a low rate of benign missense variation, in which missense variants are a common mechanism of disease. I will not go into detail into all of these pathogenic criteria. And next to these criteria for pathogenicity, there are also 12 criteria for the evidence of benign impact that are all shown in this table. So the first one is a standalone, and that's when a variant is very frequent in control population, and then it's called BA1. So that's a very strong standalone criteria that the variant is benign. Next to this, there's our strong criteria and supporting, and the naming is the same as with the evidence for pathogenicity. So B stands for benign, S stands for strong, and this is number 1 of the different strong criteria. BS1 stands for an allele frequency that's greater than expected for the disorder. You also have supporting, then we use the P again, BP3, for instance, are in-frame deletions or insertions in a repetitive region without a known function. Now, again, you have a complete list of different criteria, and I don't want to go into detail, as I said before, because probably you forget it within a minute. But within the example, some of these criteria are explained in more detail. And also the authors thought, okay, this is quite a huge amount of information. So they made this nice framework, which is present in the paper. And then in this framework, the different criteria were categorized, for instance, on population data. 3 criteria fulfill that category, and they made all these categories, and then they divided the table in benign criteria and pathogenic criteria, and then the different levels, the different weights of the criterion are stated here. So you can take your variant, take this framework, and then look for your variant. Okay, does it fulfill this criteria? Check. Does it fulfill this criteria? Check. And you can just use this table to see which criteria are fulfilled by your variant. But then you have variants with lots of criteria, but you still don't have a classification. So how do you come from this criteria to a classification? Therefore, they have this table, and it's in this table, the rules for combining criteria to classify sequence variants are stated. So for instance, if you have 2 pathogenic strong criteria, here it is, here it is, 2 strong pathogenic criteria, then your variant is classified as pathogenic. If you have 2 supporting benign criteria, 2 or more, then your variant is classified as likely benign. But what does pathogenic and likely benign mean? So pathogenic means the variant causes disease. Likely pathogenic means that the probability that the variant causes disease is greater than 90%. And I already saw that in the presentation of Elfride, it was 95%, and there's still some discussion between the 90 and 95. But in this paper, they say it's above 9, it's greater than 90%. Likely benign means the probability that the variant does not cause disease is greater than 90%. Benign means the variant does not cause disease. And if the variant does not fall in any of these above categories, it's called a variant of uncertain significance. And thus, we don't know whether it's benign or pathogenic. Again, a table with lots of information that doesn't work for me. So for myself, I made this graph with the overview how to classify your variant. The colors are the same as the framework. And for instance, we had the 2 pathogenic strong in the table. We looked them up. It's the shaded red. Then you look here, 2 shaded red. Then you fall in the pathogenic category. If you have 2 benign supporting variants, then it's 2 blues. Then you look here, and then your variant is classified as likely benign. So I always use this graph if I'm classifying variants to determine which classification belongs to my variant. So now I want to go, I'm getting already into the last part of my presentation, but it will take the longest. So I want to show some examples in which we interpret sequence variants in rare eye diseases. And my first example is a male with the clinical diagnosis of aniridia and exome sequencing with analysis of genes involved in rare eye diseases determined this PAX6 variant. So we have our variant. Now we take the framework and we look which criteria does our variant fulfill. So the first category I want to go into is the population data. So the best place to look at population data is GNOMAD. A lot of control populations have been sequenced and put into one big database called GNOMAD. And I looked up my specific position of my variant. And over 280,000 alleles have been genotyped at this position, and the variant was not detected at all in any of the controls. So if I get back to our framework and just take the population data category, then you can say, okay, my variant fulfills absent in population databases, so it fulfills the PM2 criterion. However, in 2020, the ClinGen sequence variant interpretation working group proposed to decrease the weight of criterion PM2 because they believe that being rare is not enough weight for a moderate pathogenicity. So they said, okay, we have to decrease this to a supporting level. However, then there was a problem in the naming because if you change PM2 to supporting PP2, PP2 already exists in the supporting. That's about a low level of benign missense variant in a gene in which missense variants are causing disease. So it could not be changed to PP2 because that name was already taken for another criteria. So what they now do is that we have the PM2 criterion. That's PM2 is for the absence in population databases. But then if we change the level, the weight of pathogenicity, we put an underscore and then put a specific weight we're using. So this is PM2 supporting. So this variant, we now can use PM2 supporting. So this one we cannot use anymore. It's proposed, we do not use it at the weight moderate, but we now use it at PM2 supporting, absent or very rare in population databases. So check PM2 supporting for our variant. So the next category I want to discuss is computational and predictive data. As you can see, our variant is a frame shift variant. And if you go to the end of the framework, you can see here a predicted null variant in a gene where loss function is a known mechanism of disease. And then we can say PVS1. So it seems quite easy. We have a null variant. PAX6 is known gene where loss of function is a known mechanism of disease. But of course, it's not as easy as it looks. Also for PVS1, recommendations have been published. And this single criterion, this complete framework, a flow scheme has been made. So there are different types of null variants, and PVS1 can still have its attended strength of very strong, but it can also have a strength of supporting in the case of initiation codon chains. So if you go to our variant, it was a frameshift variant, so we take this part of the flow scheme, nonsense or frameshift. Our variant is predicted, our transcript is predicted to undergo nonsense-mediated decay. Decay is present in exon 11 of 13, so we predict that the variant will undergo nonsense-mediated decay. And also this exon 11 is present in a biological relevant transcripts, in all biological relevant transcripts. So we can use the PVS1 at its original strength very strong. So we can check this one, PVS1 is fulfilled by our variant. So now we went through 2 of the criteria. You have to believe me that the other criteria are not met for this variant. Because of time, I cannot go through all of them. But we have our 2 criteria, 1 very strong and 1 supporting. So then we can look what is the classification of this variant. So we take the graph. We had 1 very strong, so 1 dark red, and 1 supporting, so 1 green. So if you go to the graph, we have here 1 red, 1 green. So our variant is classified as likely pathogenic +4. So this was the first example. Now we go to the second example. It's really nice that Elfride took the genes I also have in my presentation. So ABCA4, she already said it, with Stargardt disease. It's almost all cases are called, I believe all cases are caused by variants of the ABCA4 gene. So targeted sequencing of this gene was performed, and 2 variants were detected, 1 missense variant and 1 splice site variant. So variant interpretation, you always do per variant. So we detected 2 variants, but we have to interpret first 1 variant, and then we can interpret the second one. So we start with this missense variant. And again, I want to go to the population data. I looked up this variant in GNOMED again, and then you can see this is not completely absent. It was detected 8 times in over 200,000 alleles. So still very rare. So the supporting evidence also accounts for this variant. But the population data also has this strong criteria, and the prevalence in affected is statistically increased over controls, and that's criterion PS4. So Parsum is a really nice website. If you interpret variants, you still have to look at the data themselves. Also, Parsum does some ACMG, AMP interpretation themselves, but never believe it. Always look to the data yourself. But what is really handy for Parsum is that it shows how many publications and shows the populations in which this variant has been detected. So this variant has been detected in over 40, or has been described in over 40 papers. So probably is also present in 40 or more patients. And then this nice paper was published in 2017, in which they did a meta-analysis of just under 6,000 ABCA4 variants. And in this paper, they showed that this missense variant is significantly enriched in patients compared to controls. So we first said it was very rare, but now we have shown that it's significantly increased in patients compared to controls. So instead of PM2 supporting, we can now use PS4, which has a strong weight. So it's more increased weight to determine the pathogenicity. So our variant fulfills PS4. Then I want to go into the computational and predictive data. And this is a missense variant, so we cannot use PVS1, but we can look at BP4 and PP3, and they're almost the same. Multiple lines of computational evidence suggest no or do suggest an impact on the gene or gene product. So for missense variants, REVEL is the most commonly used tool to determine pathogenicity, to predict pathogenicity. So REVEL is an ensemble method for predicting the pathogenicity of missense variants, and it's based on a combination of scores from 13 individual tools. And REVEL will give a score between 0 and 1. In the paper, they state that the REVEL score above 0.5 corresponds to a sensitivity of 0.75 and a specificity of 0.89. So what cutoff do you have to use? Another paper has been published about the cutoff of REVEL and the PP3, how you can use it, but due to time, I will not go into that paper. But I looked up the REVEL score of this variant and it's 0.93. So I'm really confident that we can use PP3 for our variant. So we can, the computational, there's multiple lines of computational evidence that this variant has a deleterious effect on the gene or gene product. So our variant fulfills PP3. And the next group I want to get into is allelic data. And I already said it when I explained the rules, that there is one criteria specific for recessive disorder, and that's detected in trans with the pathogenic variant, PM3. But also for this one, recommendations have been published, and instead of looking at a single proband, they said, okay, just look at all probands that have been published in literature that are known in your laboratory, and look whether there's a second variant found. When the second variant is found, whether the second variant is pathogenic or likely pathogenic, or whether it's a variant of a certain significance. Then look whether it's confirmed in trans or the phase is unknown, or whether your variant occurred homozygous. And for each proband, you can give a point. Then you can take the sum of all points of all probands, and then you can determine the weight for PM3. And that can go from supporting to very strong. So I looked into literature, and our variant was found over 4 times compound heterozygous with a pathogenic variant. So we have a score of 4. So we can use the PM3 with the weight very strong. So we can check this box. Yes, our variant fulfills PM3 with the weight very strong. As I said before, this variant was published 40 times. So there's also a category called other databases in which you can use other sources as a criterion. However, it's now proposed that these two are not used anymore. You should go look into the paper or go ask for information about the laboratory who made the classification, and look and ask for the data they used for the classification, and use that data in the scheme and not just their conclusion. So you really should look at the data instead of only the conclusion they make. So at the end, for this variant, we have 3 criteria that are fulfilled. The others are not fulfilled, but I will not go into that detail because of time. So we have 1 very strong, 1 strong, and 1 supporting criteria. So we go to the graph. We had 1 strong, dark red, 1 very strong and 1 strong, 1 dark red and 1 shaded red. So our variant is classified as pathogenic. Then this girl had 2 variants ABCA4. Next to the missense, also this splice site variant. And before I showed REVEL, which is a tool for missense variants, and for splice site variants, you can use Splice-AI, which is an open source deep learning splicing prediction algorithm that predicts splicing defects caused by DNA variation. And also, again, you get a score between 0 and 1. And which cutoff you have to use, I will not go into detail. But if I look to our ABCA4 variant, you will get 4 scores in total. You have to look at the delta score, which is the difference between the ref and the alternative. And you can see the loss and the gain. And for our variant, it's all right near 0. So no effect on splicing is predicted. So then if we look, we can say, okay, our variant fulfills PP4 because it's predicted that nothing occurs on splicing due to this variant. Now I want to go into the functional data and then on the functional studies. This variant has also been published a lot, and this is shown in a patient and photoreceptor progenitor cells in a patient who is homozygous and heterozygous for this variant, that this variant does have an effect on splicing. Although it was predicted to have no effect, if you do functional studies, it's shown that this variant has an effect and causes the skip of exon 39 and the skip of exon 39 and 40. So with this data, first of all, you can rename the variant because you now know. Here you say you don't know the effect on splicing, but we now do know the effect on splicing, so we can rename the variant. And we also can say that it fulfills PS3, strong evidence for this variant. So our variant, I just show you our variant fulfilled 3 criteria, but this criteria is a prediction, and we have shown with functional studies that there is an impact on splicing, so we can get rid of this one because it was a prediction, and we have shown with functional studies that there is an effect on splicing. Moreover, in literature, I found out that TM3 very strong also is fulfilled by this variant. So we still have our 3 criteria, 1 very strong and 2 strong. Then we go to the graph again. We have 1 very strong and 2 strong, 1 red and 2 shaded. Now, with 1 red and 1 shaded red, you already have pathogenic classification. So our variant is classified as pathogenic. I have another example, but I'm at the 25 minutes, so I'll stop. And maybe my presentation can be shared, and then people can look at this last example.
Thanks a lot, Lonneke. This was really interesting. This was crystal clear, in my opinion. Thanks a lot for sharing the tools for doing variant interpretation and for also pointing out the complexity we are all facing with. So then it is my pleasure to introduce the third speaker of tonight, Professor Frans Cremers, as I said, working at the Department of Human Genetics at Radboud University Medical Center in Nijmegen in the Netherlands, the same department as Lonneke. Professor Cremers is well known for the identification of IRD genes, and last year Frans had a special interest in the ABCA4 genes, identified a lot of non-coding deep intronic variants in this gene, and I'm sure we will hear about ABCA4. Frans took the lead in establishing the Leiden Open Variation Database for IRD, aimed to register variants, published variants, and has done tremendous efforts to collect over 200 non-syndromic IRD-associated genes variants therein, including Usher syndrome and Bardet-Biedl syndrome. The talk of Frans will be on the collection and classification of variants associated with rare eye diseases, but IRD will be used as an example. So Frans, floor is yours.
Thank you. Thank you for the nice introduction. And I'm also happy that both of you gave these talks because it makes my life a little bit easier. So yes, so I will focus more on, let's say, how we can interpret large data sets, in this case on ABCA4. But let me go through the slide a little bit more. You can see, yeah. So we know that with a tremendous number of genes that underlie the IRDs, and we have to make use of the complexity of this too, and see whether can we make sense of this. So the talk will be about 3 topics. As introduced by Elfride, I will talk about Leiden open variation databases, specifically on ABCA4. I will talk about a study that we published last year, which I think is an important, let's say, paper on the offspring risk calculation for Stargardt disease, because it is quite a frequent disease. And the last part will be about our most recent studies, in which we came to a new and updated classification for all variants in ABCA4. So first about the Leiden open variation databases. So when we started this project, we did not know what to expect in terms of numbers, but clearly there are more than 100,000 cases already published and more than 150,000 variants already published. So the question that I asked myself, and together with me, other colleagues, how can we make use of this huge amount of data? Well, we thought just start collecting them, because the data are in papers, published papers, so why not already collect them and see whether we can make use of those data? So if you think about databases, I think most clinicians and for sure clinical molecular geneticists, they're using at least 2 and maybe 3 of these databases. So I will not go into all the details, but HMD Pro is a not open access and quite expensive, but up-to-date database that you can use to find variants in all the genes that are found in humans. It has advantages and disadvantages. Some of them disadvantage would be that there is no family data, so you rely on proband data. ClinVar is an open access database, mostly filled with diagnostic data. It is quite up to date, but it also contains no family data of the problems. And I would say there's no consensus variant classifications that would help make your life a little bit easier to come to a final conclusion for some variants and some genes. So I will focus the next part of my presentation on the Leiden open variation databases that is open access, that has RNA notations on top of the DNA and protein notations. It contains for IRDs now all the variants and cases, and it has expert variant classifications for selected genes. That is also immediately a disadvantage, because that it is only for selected genes means for many genes there's no expert variant classification. So for most genes, I can already tell you, all that we uploaded in LFVD is what was published in the papers, and not more and not less than was in the papers. But for some genes, it can be taken forward by each of us, and maybe then to try to make sense of the large set of data. So what we have done for LFVD in the last 3 years, we collected all the cases and all the variants for the genes that were known at that time for non-syndromic IRDs, all the Bardet-Biedl syndrome genes, and all the Usher syndrome genes. And 3 years ago, that was sort of 200 genes, and we took that forward. So I was happy to get to involve in the study all the colleagues that are listed here. I may have forgotten the one or the other one, but we split up the different conditions in clinical subgroups, and then you can see all the people that were involved to at least start with collecting all the papers that were published on these different clinical subtypes. So you can see all the names of our field that have been providing all this kind of papers. So we were lucky to have funding from the FFB USA, and the project had 3 main goals. The first goal was to collect all the publications from all these genes. And I'm happy to say that in 2020 and 2021, we were able to collect all the data from all the papers that were published up to 2019. And for some papers or some genes also up to 2020. A total of more than 4,000 papers were uploaded in the different portals that was established for this particular project by the Leiden colleagues. So just to give you an impression, you can see here a pie chart with all the papers estimated for the different genes. And except for the Usher genes, which are not part of this pie chart, you can see the usual suspects of the genes that have been published mostly in the last years. And for example, for ABCC4, I'll come back to that. There's a little bit more than 400 papers that were published. And all of these 4,000 papers were uploaded in different portals for each individual gene. So then the next step was extract all the variants and cases from these and upload these in LFVDs. And this was done by 2 colleagues from this project. And they together were able to then extract 150,000, around 150,000 variants from a total of about 100,000 IRD cases from all these different papers. So this was a huge task, which was completed already last year. And now, in these years, this year to date, but also maybe next year, we will be doing the following, which is to take all this data, this wealth of data, and try to make sense of the data. So what we are doing now, and what I hope but also other colleagues will do, is to take all the data and now to use the, let's say, the newest classification criteria based on ACMG AMP for all the variants, and then put them into mutation update papers so that we get the most recent take from all this data. And I think it has been done quite completely already for these 5 genes that are listed here: ABCD4, CNGA3, CNGB1, BPH2, and Usher2A. And you can find the references at the bottom of this slide. There's more genes to be done, of course, for the next years. And I think there's prioritization for some genes that you will find listed here also. And of course, this will be mostly focused on the genes that now are already in a clinical trial situation. Because I think there we can make best advantage of getting this data into the most updated classifications. Just to show off a little bit of the work, with all the work that we have done, but also the work that was done by David Baere in Montpellier, now HC4 and USH2A are ranking among the top 6 human disease genes where most variants and cases have been uploaded into databases. And I think this is really an important feat based on all the work that was done. I think only CFTR is missing because the CFTR variants are in a separate database. So just to give you a small peek of how you can use these LOVDs, if you type in www.lovd.nl and then the gene symbol, for example, IPC4, you go directly to a homepage of any of these genes, and then you can get this information here. Based on this, you go then to the next part, which is you could highlight the unique public DNA variants that are reported, in this case, almost 2,400 for IPC4. And if you click on this number, then you can go to the actual site, and then you find in different rows, in this case, 2,400 rows with the variants from 5' to 3', depending on how you arrange the data. You can click here on reported, and you get from the most frequent to the least frequent, or vice versa. You can base it on the exon number, then you go from the 5' to the 3' end, and you can find more data in each of these lines. An important other aspect is this button here, because if you click on this one, it gives you the expert classification, meaning it's a summary record that contains the most recent and the most, let's say, trustworthy data for this particular gene and variant in that gene. So if you click on that button for IPC4, you get this classification method and the final classification, in this case based on a 2017 paper that we published already some years ago. And then you can find all the variants listed here, and you can find the clinical classification based on the Richards et al. Classification criteria. And of course, in the last part of my talk, I will give you some details on an updated record of this, which is not yet uploaded at LOVD. So this is still, let's say, the old information, which is still pretty accurate, but it was just for these 840, let's say, variants. So in the next part of my talk, I will give you two parts extra. One is what we published last year is we not only looked at, in this case, not at ASMG in P classifications, which I will deal with at the end, but here we did a severity assessment for all the IPC4 variants. And of course, that needs a little bit of an introduction. And for that, we used the data that was collected up to December 2020. So we had more variants and more cases to be analyzed in this way. So Stargardt disease is a genetically homogeneous disease because only IPC4 is involved, as we believe. It is the most frequently mutated gene in IRDs, and it has, let's say, cone over rod degeneration. So you could see it as a maculopathy, basically. If you look at the different mutations that we find in this recessive condition, if you have two severe mutations, you end up with a very early onset severe cone rod dystrophy, or you could say an early Stargardt disease. If you have a severe and a moderately severe variant, you end up with a cone rod dystrophy. If you have two moderately severe variants or a combination of a severe and a mild variant, you have classical Stargardt disease. If you have a severe variant in one allele and a very mild, we call it a reduced penetrant variant on the other allele, you end up with late onset Stargardt disease. And we consider that there is a threshold of remaining APC4 activity under which you have a Stargardt disease, any of these phenotypes, above which you have a normal phenotype. So this threshold is arbitrarily set now at 30%. It could be a little bit less or more, but there is a threshold, and that determines whether you have disease, yes or no. So the next part will be about Stargardt disease offspring risk calculations. And it's important to realize that we are looking at variants that in a normal situation, you would only look at these 5 categories that were already mentioned by Lonneke. So you would look at the variant of unknown significance, likely pathogenic and pathogenic. But now we have to shift gears a little bit, because now these three groups, and maybe a few of those, will now be put into one of these four categories. Severe, you could say, the non-alleles mostly, moderately severe, mild complete penetrant, and mild incomplete penetrant. So we're really shifting gears because this makes life a little bit more complicated. So let's look at the most simple situation. We have here a male that is affected with Stargardt disease, and he carries a severe variant on one allele and a mild complete penetrant variant on the other allele. So the question is, what is the risk that that individual, this male, has a child with Stargardt disease in his or her lifetime? Of course, to know this, we need to know what is the chance that the unaffected spouse carries an APC4 variant, and secondly, what is the type of variant that is present? Because you can understand already that the type of variant will also have some effect on the risk for the offspring. So what we have done is, what Stephanie Cornelius has done, she collected all the publications for APC4, more than 400, registered all the variants and cases in this database, selected all the variants that were found in likely biallelic cases, determined the allele frequencies of these variants in GNOMAD, in a control population, and classified these variants from all these cases according to severity. So what do? You look at all these different types of variants. Moreover, you then look at, for each subcategory, you calculate the sum allele frequencies in the population. And so that is a huge enterprise, because first you have to classify all these different categories. So how do you classify these? So let me give you an example how we do this. For the severe group, we consider that these are all the null alleles. So the nonsense mutations, the frameshift mutations, canonical splice mutations, and the exon deletions that all lead to a truncation in the open reading frame. And if we do an RNA splice assay, in which I will not go into the detail, if less of 20% of the product is correct RNA, we say this is severe. And all the variants, also the missense variants that are in trans on the other allele with this very mild variant, we also consider those to be severe. Because according to the model, because this is a very mild variant, you can only have Stargardt disease if the other allele is now severe. So what we do is, for the 883 variants that we in this case could group in this way, we take all these variants that we put in this category, and then we looked in GNOME-ED what is allele frequency for 1, 2, 3, up to 883. And then we add up all these allele frequencies and we come to this number of 0.004. So this is 0.004, and we did the same for all the other categories. And of course, I cannot give you all the details here because this is a huge amount of work, but we came up with our best estimates of the sum allele frequencies for severe, moderate severe, mild incomplete penetrant, and mild incomplete penetrant. So what can we do now? We can now put these into the scheme and say this is our best estimate for the sum allele frequencies in the population for these four categories of variants, which then leaves us with a wild type configuration in 92% of all the individuals. So this is our best estimate. You have to read the paper to see the details of this, but we can now use this to our advantage. And of course, we have an individual that is affected that has that will transmit one of the two alleles to a child. And then if we take all the numbers from the spouse, if there's no a priori information for the spouse, we now determined that for an offspring of this male, that the chance that that child will have Stargardt disease in his or her lifetime will be 1 in 59, 1.7%. Moreover, we have done this for all the categories. And again, it's a long story, but if you look at the details in the paper, you can now see the risks for each of these situations that is there in the affected individual to have a certain risk in the offspring. So this number gives you the lifetime risk for that individual to get Stargardt disease. And that is a lifetime risk across all conditions, so early onset up to late onset. So the last part of my presentation will be about updated ACMG AMP classifications for APC4 variants. So Lonneke already introduced to you the different, in fact, 7 different classes, which are based on the Richard et al. Paper. So I will not go into these again, but we talk about these 7 groups that Lonneke already introduced to you. And you can see the underscore, the underlined letters which we have used to give all these different abbreviations. And I use these colors now to show you how we have used this. So in the Richard et al. Paper, each of these categories gets a different weight. So as Lonneke nicely illustrated, the PVS, pathogenic very strong, has a higher weight than the PS, strong, moderate, or supporting. And likewise, there is a different weighting for the different parts. For benign standalone is the strongest one, and then you get weaker weights. But this is still quite difficult to use. And Lonneke already showed a scheme in which you can put them all together. But there's now also a paper that was published 3 years ago by Tavtikian et al. And they have now used a point system where they now give a weight to all these different groups. So each of the 7 categories now gets a number. So PVS has a +8, PS +4, PM is +2, PP supporting is +1. And if you go below 0, BP is now -1, BS is -2, and benign standalone is -4. So this gives you a nice counting system to now mathematically show what you're looking at. And now it gets a little bit more intuitive, because now we can see what the different relative weights is for each of these categories. And so +8 clearly is twice as much as this, and that is twice as much as that, etc. So it's a nice mathematical configuration now to weight all these different groups. Lonneke already introduced all the different sub-criteria that are there to find this data, and we've used all of this according to the latest updated parts of this to come up with the scaling system to now do this for APC4. So, and if you look at the scaling system, it means that if all the points together, the sum of the points is +10 or more, then we have a pathogenic variant. If it's 6 to 9, it's likely pathogenic. If it's 0 to 5, it's a VUS. If it's -1 to -6, it's likely benign. If it's -7 or less, it's benign. So we've used all these different criteria that Lonneke just illustrated, and Stephanie Cornelis has used all of this information now to use the system as Lonneke already introduced to you. And just to give you a few examples, and then not just a few, not examples of patients, but just of the categories, PVS1 would be a nonsense variant, a frameshift variant, or a canonical splice set variant, protein truncating, and it gives you +8 points. If a variant would be enriched, in this case in biallelic Stargardt cases versus GNOME-ED, it would give you 4 points extra. And for example, if it would be a gain or loss of one amino acid with at least one nucleotide or more than one nucleotide to have a final p-score of more than 7.4, you get 2 extra points. So in this way, and for using the different, let's say, criteria, you just add up all these points. And if this is 10 or more points, you then will classify this as a pathogenic variant. So likewise, as an example for the benign categories, if you have, for example, an allele frequency of more than 0.019 in the GNOME-ED population, it will give you -4 points for benign strong. If it would be, for example, a missense variant with a Revel score less than or equal to 0.13, it would give you -2 points in the point system. For other variants that cannot be graded in the Revel, it would be, for example, a CAT score below 17.3. It also would give you a -2 score. And for example, a synonymous variant that has a splice score less than 0.19, which is sort of the cutoff, you also get -1 point. So if you add up these minus points, you could also end up in the likely benign or in the benign category. So in doing all of this for all the variants in APC4, we could classify more than 2,000 variants according to all these guidelines. So it's the guidelines from the Richard-Zal paper, but then with all the updates that have come in literature in the last couple of years, and probably will be published at the end of this year as one new paper, we could then classify all the variants according to these different groups. And that's what we've done. So we now have about 800 variants in the pathogenic area. We have 450 in likely pathogenic, 800 in FUS, 180 in likely benign, and 12 in benign. And so this paper has been submitted to a journal, and it has been resubmitted very recently. But you can also find the paper in this medRxiv location. So if you would go to just to Google Cornelis and APC4, you probably will get this immediately in your first hit. So that gives you all the data on APC4. So the take-home messages from my talk are the following: that we have accomplished to get all the variants and cases that were published in literature up to 2019 for close to 200 genes involved in IRDs, that we did, and other people did, the variant curation and the ACMG AMP classification for 5 IRD-associated genes quite recently, including APC4, that we also did a severity assessment based on splice assays, though I didn't talk too much about this, and in silico analysis for APC4 variants, that we established, which I think is clinically very relevant, an offspring risk assessment for APC4 retinopathy for all combination of variants and all human populations, because you can see all this data in the supplementals of the paper. And maybe also to ask the whole community, it is important to do this comprehensive variant analysis, as I've shown for APC4, to also do this for other genes. And I would like to call upon all my colleagues to contact us and to ask for all the data that we can extract now easily from all the LFODs that you can take forward to do also a variant analysis for all your gene of interest. Please do so, and it would be highly appreciated if you would do so. So finally, I would like to thank all the collaborators that did most of this work, Ivo Fokkema from Leiden, and Stephanie Cornelis mostly for all the APC4 work. So with that, I would leave the study and will now stop the sharing. Thank you.
Thanks a lot, Frans, and thanks again, Lonneke, for the great and crystal clear talks. I would like to thank you, the participants of this webinar, very much. I hope you found it interesting and that you learned a lot. And I would also like to thank, of course, the speakers. Lonneke, again, thanks a lot, and Frans also, thanks a lot. And you will find the link here in the chat, the link of the recorded webinar, so that you can go back to the presentations and also advertise the webinar with your colleagues. So thanks again, and see you soon at ERN-EYE meeting or at the next webinar.